Well, let's get started. We're going to talk about Unit 1, which is donors, and this correlates with your textbook, Chapter 13. Please review your textbook as well as this presentation to get the most out of both. The following slides will provide an overview of the process involved in the collection of donor blood. Your first and foremost resource for anything related to transfusion medicine is provided by AABB.org. This is our professional organization which to a certain extent regulates donors as well as transfusion medicine. The criteria for the screening and acceptance of donors changes frequently. This presentation that you're hearing right now has the most up-to-date information as of January 18, 2021. Your textbook was published in 2017 and may have information that conflicts with what is present in this presentation. For exams, you are to go by the information presented here if it differs from the textbook. And again, the most relevant resource for current information is found at the AABB.org website. We're first going to talk about donor screening, and donors are our most precious resource. All blood for transfusion into humans comes from volunteer donors. They are not paid. In fact, I wanted to give extra credit. We had done a tour of the blood center. If students wanted to donate, I would give them extra credit. And the director told me, nope, that would be considered a payment and we cannot pay our donors. Although it's okay for them to give us ice cream and t-shirts, but it matters not. I just found that amusing. And every year I would check, and every year the answer was the same. No, that's considered a form of payment. So the screening is performed to ensure the donor is healthy. And it starts with the donor, and first impressions are critical. You want a clean, well-lit donation facility from waiting room to collection area. I don't want to see paper on the floor, dust bunnies in the corners, cobwebs on the ceiling, because as a donor, if this was my first time, I would turn around and walk out and say, if this is the best you can do, I'm really afraid I may catch something by donating blood. You want to have staff that are pleasant and professional and who can ask the appropriate questions, observe and interpret the responses, and ensure that the collection process is as pleasant as possible. A lot of people, including my colleagues, get confused with the terms blood bank versus blood center. And sometimes they utilize these inappropriately. A blood bank in a hospital is also known as the transfusion service. They perform the compatibility testing and they prepare components for transfusion to the patient. They have nothing to do with rare exceptions with collection of donor blood. They're simply there to use the components to treat patients. A blood center is the donation center, which screens donors, draws donors, performs testing on the donor blood, and delivers appropriate components to the hospital blood bank. So blood bank transfusion service, blood center, donation center. Blood is a very highly regulated product. There are standards, there's regulations, and there's governing bodies. Strict guidelines exist and inspections are performed in both blood centers and blood banks to ensure the safety of the donors and the patients. Some or all of the following agencies may be involved: Food and Drug Administration and CBER and CFR. These are regulations about making blood components because we don't use blood as whole blood. We make it into components, and those components can be further made into components. So you have to follow the guidelines that these processes and procedures are in line with the standards. AABB, which was formerly known as the American Association of Blood Banks, it's now an international organization, so they didn't want American in the title, so they've just gone to the acronym AABB, which drives me crazy. Letters should mean something. CAP is the College of American Pathologists, and they inspect laboratories every 2 years. Joint Commission inspects hospitals every 2 years, and that will include the lab. And CLSI, which is the Clinical Laboratory Standards Institute. So if it's a carefully regulated industry, which is good because this is the area of laboratory medicine that you can do the greatest harm. Let's discuss the donor screening process. The 2 goals or purposes for screening are as follows, and notice these words are big and bold. I expect you to remember these. Protect the health of the potential donor. We do not want them to donate a unit of blood and fall over dead. And protect the health of the potential recipient. We do not transfuse blood and components into healthy people. They're sick. And so if we give them something in a blood product that causes them to have adverse effects, and they could potentially die. There will be 4 outcomes to the screening process. We're going to accept the donor. We're going to temporarily defer the donor. The donor may be indefinitely deferred, meaning once a resolution to this particular issue is found, it will be recategorized, and permanent deferral. Screening of the donor is divided into 4 phases. The registration, educational materials which are given to the donor, health history and interview after they've reviewed the educational materials, and then if they successfully pass the history and interview, the physical examination. Once the donor successfully completes the donor screening process, they will be taken to the blood drawing area. As you can imagine, during the donor registration, the donor will sign in. They will be given written materials which will explain high-risk activities which may make the donor ineligible to donate blood. The donors must be informed and give consent that blood will be used for others unless they are in a special donor category. For example, Jehovah's Witnesses do not believe in blood transfusions. But there is one segment of Jehovah's Witnesses that believes that blood can be used if it's their own. In the notes section, I've given you a URL. These ethical decisions which are made, sometimes based on the patient's personal beliefs, sometimes are very, very difficult for us personally to handle in the laboratory. First-time donors must provide proof of identification that's required by the specific facility, which may be Social Security number, driver's license number, date of birth, their address, and any other unique information about the donor. Repeat donors may be required to show their driver's license or some other photo ID. The date of birth is very important because donors must be at least 16 years old to donate blood. Now, in some states it may be 18, other states it may be 17. But the minimum is 16. If the state considers a 16-year-old to be a minor, then parental consent is required. The frequency of donation is also checked during the registration process to make sure that they're within the window of donating again. For whole blood donations, it's 8 weeks. A 2-unit red cell collection is 16 weeks. Plasmapheresis is 4 weeks. And 2 days or more after plasmapheresis, plateletpheresis, or leukapheresis. Plateletpheresis can be done no more than twice in a 7-day period and no more than 24 times per year. Plasmapheresis can be done once every 4 weeks, and it can be done twice a week. The frequency of donation is very important because we are withdrawing a certain volume of the patient's blood, which includes red cells, white cells, platelets, and plasma. And in order for the body to return to normal, it takes specific periods of time. Additional useful information, the name of a patient or group to credit. I don't know if they do this anymore. I meant to check on this. But at my institution, if insurance does not cover blood donations, then for every donor that you get to go donate in your name, they will remove that cost of that unit of blood. And blood has become very, very expensive because of all the testing that must be done. The donor's race, as you will learn, there are certain antigens found predominantly in white people. There are other antigens that are found predominantly in black people. So knowing the race allows me, as a medical laboratory scientist, to know what I'm looking for, an antigen that is most likely going to be lacking in a black person. So I'm not even going to try the white people because they're going to be 100%. So it's not that we're racist in any way, shape, or form, but as scientists, we look at the statistics and we want to select the population that will have the highest level of success in finding what I need. And other unique donor characteristics. As we learn about the different blood groups, once donors are typed for, there's hundreds of other antigens that are present on the red cell, this has gone into the system so that if I need a unit of CalNeg, WA-neg, Big E-neg, I can call the blood center and they can screen their records and find a donor and perhaps ask that donor to come in and donate. Educational materials. Donor must be provided with HIV high-risk activities, information about travel to other countries and which countries would prevent them from being a blood donor. Warnings about donor reactions. Donating blood is not without risk, but most of the reactions that donors have are very mild. Post-phlebotomy care instructions, because they use a 16 or 18 gauge needle. That's really big, and so it's very important that they take care of that wound. And what types of testing will be performed on their blood and how they will be notified. For example, HIV test comes out as positive. You have to have a way to get that donor the information in as secure a manner as possible. The next process is the medical history. Health history assessment is performed using a donor history questionnaire, and a thorough history is obtained each time the donor shows up to donate blood. A standardized universal questionnaire is used, and this same questionnaire is used throughout the United States. And this will be the basis for your lab, that you're going to actually use the standardized questionnaire to ask each other questions and have a little fun with the lab. You know, if you want to be a prostitute, or if you want to be an IV drug abuser, if you want to be, I don't know, if you've taken a certain medication, but don't go crazy. Just list 2, maybe 3 different positives. Or if you're a nice person, you know, answer everything in the affirmative so that you can be accepted. Another question that's asked is, has the donor ever been deferred? And if yes, why? So, for example, maybe the donor came in last time and they were just recovering from strep throat. So the donor's sick. So we don't want sick donors to go ahead and donate blood. So they will be temporarily deferred. And you ask them and they said, yes, I've been deferred because I had a positive test for hepatitis B. Well, somebody didn't explain to them last time, or maybe the donor didn't understand that this is a permanent deferral. They may never donate blood again. We also ask them about the medications that they're taking, because medications the donor takes may be present in the plasma and may be cause for deferral. For example, think penicillin. Many people are allergic to penicillin. And if you're on penicillin, number 1, that means you're sick, so you wouldn't be accepted anyway. But number 2, if penicillin is present in the blood components, then that could lead to a really severe reaction. I've given you a list of medications to memorize, but know that there's thousands of medications. And what the interviewer does is just look them up in the database to determine whether or not it's a reason for deferral. Infections the donor has may be passed to the recipient and may be cause for deferral. For example, the patient says, I'm just getting over strep throat. Well, it needs to be a certain amount of time, so you will temporarily defer them and tell them to come back maybe, 2 weeks after the infection has resolved. Other infections such as hepatitis B or HCV, these viral infections can be transmitted through blood and blood products, so that would be a permanent deferral. I've used some examples for deferrals, but now we're going to go into the classification. So a permanent deferral, they can never be a volunteer donor ever again. It's permanent. HIV, hepatitis B. 12-month deferral due to intimate contact with a permanently deferred donor. So if the person's spouse or significant others has HBV or HIV, then the spouse or significant other cannot donate blood until 12 months after the last intimate contact. Indefinite deferrals, these may be medications or some other conditions which may be accepted over time. It's crucial that donors are as honest as possible during the interview so they do not put the lives of sick patients at risk. And this is something that's emphasized during the donation process. It's up to the donation center whether to meet or exceed these requirements. And I'll talk about some of these. These are the minimum requirements, but if you wish to set your standards higher, that's fine. Let's talk about the permanent deferrals, and you must memorize each and every one. And there's probably more, but these are the ones you are responsible for. Males who had sex with males or engaged in sex for drugs or money since 1977. I had a student who asked me, well, what if my boyfriend takes me out for dinner and a movie? Is that no. No, that's not considered. That is not this. If you've used IV drugs even once in a lifetime, so you're that stupid kid who in high school or college decided to experiment with IV drugs one time and you decided, absolutely not for me. Unfortunately, what that means for you is you can never be a blood donor. Taking clotting factors is permanent deferrals. The perfect example are people with hemophilia. Which factor are hemophiliacs missing? If you said factor VIII, yay, good for you. And how they make factor VIII is through a plasmapheresis program. So these centers they pay their donors for their plasma, and they have higher screening processes than they do for blood donors because they are paying these donors for their plasma. What they do with the plasma is they test it for every disease just like regular blood donors, and then they pool all the plasma together. I don't know if it's 100 donors or 200 donors, and then they process it to remove virus particles, because even though you test negative, you could still potentially have a viral infection. And then they further process it into the different components. So one of the components is factor VIII. Hemophiliacs know when they're having a bleeding episode. So I can't recall if this is kept in the freezer or the refrigerator, but they pull it out, they go ahead and draw it up in a syringe and inject it. This prevents them from having to go to the hospital. If you've had hepatitis after age 11, prior to age 11, they believe it's hepatitis A, which is transmitted through the fecal-oral route and is not transmitted through blood. Cancer deferrals vary. Some cancer patients will be accepted after a certain period of time of being disease-free. Others do not. For example, minor skin cancer, because if it's caught early and it doesn't metastasize, then after a period of time they can accept these donors. But if it's melanoma, absolutely not. If you've lived in a country where Creutzfeldt-Jakob disease is prevalent, or a family member with CJD, then you are permanently deferred. Creutzfeldt-Jakob disease is caused by a prion, and it takes years and years, but once this prion is established in your brain, it makes holes in the brain, and it's called spongiform encephalitis because the brain looks like a sponge, and unfortunately the disease is fatal. And so it is transmitted through brain tissue. Some cultures like to eat animal brains, and specifically cows. So again, if you're in a country where this disease is prevalent, then you are permanently deferred. Protozoan diseases such as Chagas disease or babesiosis, these are more prevalent in South America and other countries, but are we limited in travel? Well, now we are because of COVID, but in the past, we've seen a lot of international travel. So these diseases have been showing up in the United States, but that would be cause for a permanent deferral. If you received human pituitary growth hormone, I don't think they make it from humans anymore, but this is for people of short stature. We used to call them midgets, now we call them short people, and they, due to this deficiency of growth hormone, do not grow to a normal adult height, and their lives are very, very challenging because they have to have everything modified to where they can reach stuff. But if it is of human origin, again, it could potentially have transmitted some diseases, and that is permanent deferral. If you've had ever a previous positive test for hepatitis B surface antigen, hepatitis C, HTLV1 or 2, or HIV, your permanent deferral. Even though a test you had done recently shows a negative result, that could be a false negative. So once you're positive, you're always positive. If you've donated the only unit of blood in which a recipient contracted HIV or HBV, so the patient has no risk factors for these diseases, they were negative prior to getting this blood transfusion. Now, since they got your blood, and that was their only blood exposure, then you will be permanently deferred. And we do a process called look back in the transfusion service, which the doctor has to call us and say, hey, my patient got a blood transfusion at your facility. My patient now tests positive for HIV. Then we share this information with the blood center, and they will find out which particular donor. And so even though that donor has passed all the screening tests, they will be permanently deferred. And finally, if this donor was the only common donor in 2 cases of post-transfusion HIV or HBV, then they're permanently deferred. So this patient was given 2 units of blood, 1 of them was yours. Later on, another patient was transfused with 4 units of blood, and you were one of those. What was the common factor in both of these transmissions? You. So it's more likely than not that you were the reason that these people became infected, and you will be permanently deferred as a donor. Let's talk about 12-month deferrals. If you've received blood, components, or blood products such as coagulation factors, 12 months. If you've had a sexually transmitted disease, if acquired, indicates that safe sex was not practiced, and the donor is at risk for HIV and hepatitis B. If you've received hepatitis B immune globulin, this is given after exposure, such as a needle stick exposure, or you got blood in your mouth, or some type of blood exposure, and you have not been vaccinated for hepatitis B, then they will give you this product in the hopes that it will prevent you from acquiring hepatitis B. If you've had acupuncture, tattoos, ear piercing, some states may accept you, but others will not. Tattoos now, they have high standards for them, but let's say you went to Screwy Louie's backyard tattoo service, where they reuse needles and they reuse the paints. What should happen when you get a tattoo is they open a fresh palette of paints, they use a brand new needle, and they autoclave all their stuff. Ear piercing, these are generally acceptable, but again, it will be dependent upon your facility's requirements of whether or not these are deferred. And I have to share this story. So when we were little, we decided to pierce each other's ears, and how you did that was you got a piece of ice and you held it on each side of the ear. And then you had a threaded needle, and we passed it over a match, and you poked it through the ear. And then you went all the way through and tied the string. And you did that on both ears, and then you would move the string. Terry did not play that game. Did not think it was a good idea. If you've had the rabies vaccine, it's a 12-month deferral. Any intimate sexual relations with HIV or HBV positives, with hemophiliacs, drug users, or individuals receiving drugs for money or for sex, it's a 12-month deferral. So if you are in the risk group, it's permanent. But if you are the sexual partner of an at-risk individual, it's 12 months. So if you're married to a hemophiliac, then you cannot, or have intimate relations, you cannot donate blood until 12 months since that last intimate encounter. And finally, let's talk about the temporary deferrals that you are responsible for memorizing. Certain immunizations: 2 weeks for MMR, yellow fever, oral polio, and typhoid. 4 weeks for rubella and chickenpox. 2 months for smallpox. Pregnancy: 6 weeks upon conclusion of the pregnancy. Certain medications: I want you to refer to the AABB drug referral list in the reference section of the course for a full list. These are the ones that I'm going to have you memorize. Feldene, no platelet donation for 2 days. Plavix and Tyclid, no platelet donation for 14 days. Proscar, Propecia, Accutane, 1 month. Avodart, 6 months. Soriatane, 3 years. Tegasone is permanent because they believe that this can cause permanent mutations. Malaria is a 3-year deferral if you've had malaria. West Nile virus is 28 days. The Zika virus, you'll defer the donor for 120 days from the date of the reactive test or from the date of resolution of symptoms, whichever time frame is longer. So here are some helpful hints. So permanent deferral will include any member of a high-risk group, such as HIV, HBV, HCV positive, drugs or sex for money, cancer, serious illness or disease, CJD, Chagas disease, and babesiosis. Permanent deferral. Chunk your information. Put permanent deferral on an index card and then list the reasons. 12-month deferral. If you have sex with any person in a high-risk group, any blood exposure, any recipient of blood and blood products, sexually transmitted disease, if you've been in jail and prison for which is defined as more than 24 hours. Rabies vaccine after exposure, hepatitis B immune globulin, and malaria. So those are all the 12-month deferrals. You must memorize the medications and vaccination deferrals provided in this presentation. So you've successfully completed the registration and the oral history, and now it's time for the physical examination. So you want to evaluate the donor's general experience. Do they appear drunk or under the influence or excessively nervous? Excessively nervous people have a tendency to faint. So you would want to very tactfully temporarily defer them from donation. The weight varies, but 110 pounds is the absolute minimum nationally, although some locations may require a higher weight limit. For example, here in Austin, they require a 125-pound minimum. And I had a student who she felt it was her duty to donate blood, and they shouldn't tell her what to do. And she weighed like 95 pounds. So before she would go donate blood, she would fill her pockets with rolls of quarters, and she'd wear a sweater. And because she would step on the scale, and they'd look at her, and they'd look at the scale, and they knew she didn't weigh 110 pounds, but what could they do? So anyway, it just shows that you can be under 110 pounds and successfully donate, but it's not recommended. Temperature is 37.5 Celsius or 99.5 Fahrenheit. If it's higher, it may indicate an infection, which you may not even be aware of yet, so you would be deferred. Blood pressure, one thing to note, medications for high blood pressure do not disqualify a donor. And in the old days, we used to have a minimum and a maximum. Now they just go by a maximum. So the systolic has to be less than 180 millimeters of mercury, and the diastolic needs to be 100 or less millimeters of mercury. Hemoglobin and hematocrit, for allogeneic donors, it's 12.5 grams per deciliter, or 38%. And for autologous donors, it's 11 grams per deciliter, or 33%. And the reason for this is an autologous donor is somebody who's giving blood to be used for themselves. So the expectation is that this blood will be returned to them. So having this lower than normal hemoglobin or hematocrit is fine. Self-exclusion was rescinded by the FDA in 1992, but some blood centers may still use it. There are 2 stickers, yes, use my blood, and no, do not use my blood. And the yes and the no are on the paper, and a barcode that indicates that answer is on the sticker. So nobody knows whether you said yes or no until it gets to the back. After the interview, the donor will place the appropriate barcoded label on the donation record. And if no is selected, they still draw the donor. The unit is collected. It's fully tested, but it's not used for transfusion. This allowed donors who know they are at risk to save face if pressured to donate by friends and family. So you've always been the leader of your blood drive at work, and unfortunately you have contracted HIV. So people would question, well, why aren't you the leader of our blood donor drive? And rather than go through that uncomfortable situation, he'll go with them and he will donate blood, but the no indicates that don't use my blood for transfusion. The only thing is, well, we'll talk about directed donors later. So there are many, many different donor categories, and it kind of makes your head spin around. You're just going to have to memorize them and what these terms mean. And the first one is very confusing because allogeneic, homologous, and random donor, these 3 terms are used interchangeably for blood donated by individuals for anyone's use. This is the true volunteer donor. Autologous. This is a situation in which you donate blood for your own use, and it can only be used for you. I know my dad, when he had hip surgery, he pre-deposited 2 units of blood, and that way hip surgeries are relatively bloody, so if he needed more blood, then those would be available, and they shortened the time frame for this type of donation. What really made me angry is they didn't give that blood to my dad, and he had a low hemoglobin. But anyway, that's autologous. You're donating it for only your own use. Recipient-specific directed donation. A donor may be called in because blood or blood product is needed for a specific patient. For example, we use O-negative CMV neg for all our NICU, neonatal intensive care patients. Sometimes we run out, and so those specific donors, if it's been a while, they will be called up and asked to come in to donate. And who will turn down that your blood is needed for a baby? I mean, so you can draw those in. And there's many other situations. Now, you need to differentiate this from directed donor. This is a patient who selects their own donors. And to me, this is the most unsafe type of donation you can make, because your relative, they don't want to say, no, oh, Susie needs your blood, that's your niece, and would you please, please, please go down there? And so you feel obligated to do that. Well, you may have a disease. And we had several situations when I worked in the transfusion service when the blood center would call us up and say, hey, one of the donors for this patient tested positive. Now, they won't tell us what they tested positive for. just that they tested positive. So I would pick allogeneic over directed donors any day. And then therapeutic bleeding. This is blood removed for medical purposes such as in polycythemia vera, and it is not to be used for transfusion. And my dad, what a character. I mean, he had so many conditions. Later on in life, he did develop polycythemia vera, and once a month he had to go in and do a therapeutic bleeding to where they drew a unit of blood and then discarded it. So, in addition to donor categories, donors can also be categorized by the type of donation they do. An apheresis procedure is removal of one component and they return the rest of the blood to your body. Leukapheresis, they remove the white cells, return everything else. And it has a special filter, just like platelet pheresis is removal of platelets and then return everything else to you. There's a special filter that makes the white cells, or for platelets, the platelets stick to the filter. And that way, once the donation process is done, they put a solution that causes the platelets or the white cells to release from the filter and then become a therapeutic dose. And plasmapheresis is where they remove the plasma only and then return everything else to you. For stem cells, there's two types of stem cell donations that can be used for transplants. This is bone marrow and then apheresis. In apheresis, you have pluripotential stem cells that circulate in your peripheral blood. And what they found is it's much easier to use a filter that will pluck out the stem cells. Now, the donor is given medications to stimulate the production of stem cells to where they can get a really healthy therapeutic dose upon completion of the process. Versus bone marrow is where they have to put you under general anesthesia, you as the donor, and then they insert this large bore needle to remove bone marrow. And they use a syringe and it looks just like blood, but they have to puncture and puncture and puncture. And so it has a higher level of risk. But again, once they put this in a bag, it looks just like blood. So donor categories, the safest is autologous because the blood is your own and there's no risk of disease acquisition. The most dangerous is directed donors, where you select a donor who may, unknown to you, be in a high-risk category, but feels obligated to follow through and donate. Please write down any questions you have, and after viewing this presentation or reading the chapter in your book, you can't find the answers, ask your instructor.